Welcome back to the deep dive. Today we're kind of stripping things down, literally.
Oh, yeah. We are talking about the nudist of the bacterial world.
Exactly. Imagine a bacterium that millions of years ago looked at the rest of the microbial world. All these bugs obsessed with building thick, rigid, peptidoglycan stone walls to protect themselves and just decided, nah, I'm good.
Right. I'm going nimble.
I'm going naked. It shed the armor completely.
It is a wild evolutionary strategy. And while being naked might sound really vulnerable, for the genus Mycoplasma, it's actually this brilliant, high-risk, high-reward move. It's allowed them to become incredibly persistent human pathogens.
So today we are diving deep into Murray chapter 33, pulling in some key tactile supplements from Jerwitz chapter 25 as well. And our mission is to really understand this wall-less wonder.
Because that one missing feature dictates absolutely everything.
It really does. I love this topic because it breaks every single rule you learn in that first week of medical school. You know, you spend all this time memorizing gram stains, thick walls, thin walls, purple, pink.
And then Mycoplasma shows up and makes all of that knowledge completely useless.
Completely.
If you think of your typical bacterium like a staph or a strep as a knight in a full suit of armor.
Where the armor is the cell wall?
Exactly. Then Mycoplasma is essentially this amoeba-like blob. No armor. And that one structural decision is the key to this whole deep dive.
It dictates how it looks, how it eats, how it attacks us, and crucially, why our favorite heavy-hitting antibiotics just bounce right off it.
Right. We're going to break down why penicillin fails, why you can't even see these things under a normal microscope, and why this tiny little organism is the culprit behind that nagging, persistent walking pneumonia.
The one that always seems to sweep through college dorms and elementary schools.
That's the one.
But before we get to the clinical destruction, we really need to appreciate the sheer scale of this thing, or I guess the lack of scale. Murray opens up by pointing out that these are the smallest free-living bacteria in existence.
We have to pause on that size concept, because just saying small really doesn't do it justice. We're talking about organisms that are 0.2 to 0.3 micrometers in diameter.
Which is, I mean, that's tiny even for bacteria.
It's pushing the absolute theoretical lower limit of how small a biological cell can physically be and still contain the machinery necessary for life.
Like the DNA, the ribosomes.
Right. You literally couldn't fit the enzymes and nucleic acids into a smaller package.
Yeah.
Any smaller, and the physics of life just stop working.
It's the tiny house movement of microbiology.
That is a perfect analogy. And this size issue isn't just a fun trivia fact. It actually totally confused early microbiologists.
Because of the filters, right.
Exactly. Think back to the early 20th century. We didn't have electron microscopes. We didn't have PCR. So how did they define what a bacterium was?
They used physical filters.
Right. These porcelain Chamberlain filters.
Yep.
They had a pore size of usually 0.45 micrometers. The rule was simple. If you pass a fluid through it and the pathogen gets stuck in the filter, it's a bacterium.
Like E. coli or staph, they get caught.
Right. But if it passes through the filter, it's considered a virus.
And Mycoplasma is 0.2 micrometer.
So it slipped right through.
Wow.
When Eaton discovered the agent causing primary atypical pneumonia back in the 1940s, the bug we now know as Mycoplasma pneumonia, he called it the Eaton agent.
And everyone just assumed it was a virus.
Because it behaved exactly like a virus physically. It took decades of debate before scientists realized, wait a minute, this thing has both DNA and RNA.
Which viruses don't.
Exactly. And it divides by binary fission. And it's susceptible to certain antibiotics. It was a complete biological imposter.
So it is a bacterium, but it belongs to a very special class. Murray calls it the class Mollicutes.
Mollicutes. The etymology there is really helpful for anchoring the concept. It translates from Latin to soft skin.
Soft skin. Because of the missing cell wall?
Precisely. No peptidoglycan shell means they're soft, pliable, and squishy.
Sounds like a luxury skincare line, but it's actually a taxonomy of stealth. So the genus Mycoplasma has, what, over 200 species?
Over 200, yeah. Mostly in animals and humans. But Murray gives us a big four that you absolutely have to know for clinical practice and board exams.
Let's lay those out. Who are the main players?
The first and most prominent is Mycoplasma pneumonia.
Okay.
As the name implies, this is the respiratory pathogen.
The walking pneumonia bug?
Exactly.
Yep.
Tracheobronchitis, atypical pneumonia. It's the one causing the outbreaks in the military barracks and schools.
Okay, so that's the lung bug. What about the other three?
The others are primarily genitourinary pathogens. You have Mycoplasma genitalium.
Which we're seeing a lot more of lately.
It is becoming a massive issue in sexually transmitted infections, largely due to rising resistance, which we'll get into. Then you have Mycoplasma hominis.
What's the clinical picture for hominis?
Think postpartum fevers, pyelonephritis, and occasionally systemic infections.
Okay, so that's pneumonia, genitalium, hominis. What's the fourth?
The fourth is technically a different genus, but structurally and biologically it's grouped right in with the mollicutes, and that is ureaplasma.
Specifically ureaplasma ureolyticum.
Right. And Jalitz emphasizes that ureaplasma is a huge deal for non-gonococcal urethritis, and really importantly for lung disease in premature infants.
Okay, we'll definitely circle back to the preemies. So those are your players. M. pneumonia up top in the lungs, and genitalium, hominis, and ureaplasma generally operating below the belt.
Exactly.
Let's unpack the physiology a bit more. We've established the no wall thing. But if I'm a bacterium and I don't have a rigid peptidoglycan wall, I'm basically a microscopic water balloon. So why don't I just pop? Our bodies are full of osmotic pressure changes. How do they survive?
That is the fundamental problem of being a molecule. Most bacteria rely on that wall like a corset. It physically holds them together against their own internal osmotic pressure. Mycoplasma had to evolve a completely different trick.
And the trick is theft.
The trick is absolutely theft. Mycoplasma cell membranes are totally unique among prokaryotes because they contain sterols.
Specifically cholesterol.
Right.
But bacteria don't make cholesterol. That's a eukaryotic trait. That's an animal thing.
You've hit the exact mechanism. They don't synthesize it. They steal it from us. They are metabolic parasites. As they wander around the human host, they literally scavenge cholesterol molecules and embed them into their own cell membrane.
They use our own cholesterol as their scaffolding?
It's brilliant. The cholesterol inserts between the phospholipids and rigidifies the membrane just enough. It makes that soft skin tough enough to survive the osmotic stress.
That is wild, and this completely explains why culturing them in the lab is such a legendary nightmare. If you just swab a patient and throw it on a standard nutrient agar plate, what happens?
Nothing. They die. Standard agar doesn't have sterols. If you want to grow mycoplasma, you have to custom build the agar and add animal serum to it, usually horse serum or calf serum.
Because the serum contains the cholesterol they need to steal?
Exactly. You are artificially feeding them the structural components they refuse to make themselves.
I've always heard them described as slow and needy in the lab.
Incredibly slow. Because remember, they threw out a huge chunk of their genome along with the cell wall. They are minimalists. They lack the genetic machinery to synthesize a lot of basic amino acids and purines.
So they have to scavenge almost everything.
Right, which means their generation, the time it takes for one cell to divide into two, is painfully slow. It takes anywhere from 1 to 16 hours.
Wow. Compare that to something like E. coli.
E. coli doubles every 20 minutes. Mycoplasma takes hours. So you're waiting days, sometimes weeks, to see a visible colony on a plate.
But when they do finally grow, they look pretty distinct. Right. Jalitz has some great, very testable descriptions of their colony morphology.
Yes, this is a classic board exam visual. Because they lack a rigid wall, they don't pile up nicely on the surface of the agar like a staph colony would.
They kind of spread out.
They spread, but they also burrow. The center of the colony physically embeds itself down into the agar while the edges fan out on the surface.
Which creates that famous fried egg appearance.
The classic microscopic fried egg. A dense, dark center with a lighter, wispy halo around it. But, and this is a huge distinction, that fried egg look is characteristic of Mycoplasma hominis.
Not the lung one.
Right. Mycoplasma pneumonia does not usually give you the fried egg. Murray describes M. pneumonia colonies as granular. They look more like a mulberry.
Okay, so fried egg equals hominis, mulberry equals pneumonia. Good anchor there. Now, what about ureaplasma? The name obviously gives away its favorite snack.
It does. Ureaplasma is unique because it strictly requires urea for growth. Most bacteria can tolerate urea, but ureaplasma actively hunts it.
It produces ureas.
Massive amounts of ureas to hydrolyze the urea.
Let's do a quick sidebar on ureaplasma here, because Murray points out this isn't just a dietary quirk, this is an actual pathogenic weapon.
It is. Think about the chemistry. When you split urea, what are the byproducts?
Ammonia and carbon dioxide.
And ammonia is highly basic.
So it jacks up the local pH.
Exactly. It creates a highly alkaline environment in the urinary tract. And clinically, alkaline urine is very dangerous because it causes salts to precipitate out of solution.
Right, the magnesium ammonium phosphate stones, struvite stones.
Staghorn calculi. So ureaplasma isn't just irritating the tissue, it's practically doing chemical engineering in the kidney to build these massive stones. The urese activity is its defining feature.
Okay, pivoting back to general physiology. We've got the lack of a wall, the sterile theft, the slow growth. But what does this mean for their actual shape under a microscope?
Well, no wall means no fixed shape. The term is pleomorphic. Pleo meaning many, morph meaning shape. They can look like little round cocci, they can stretch out into rods, they can form long filaments.
Or they're just weirdly blobby.
Weirdly blobby is a very accurate scientific description here.
But this leads to a massive problem for us in the hospital. The Gram stain is the cornerstone of infectious disease. It's the very first thing we do. We dye the shirt the bacteria is wearing.
But Mycoplasma isn't wearing a shirt.
Exactly. So you pour on the crystal violet, you add the iodine, you do the alcohol wash, and the dye just washes entirely away. What do you actually see when you look in the microscope?
You see ghost cells? Well, you see the human cells. Lots of angry neutrophils, lots of dead epithelial cells. But where the bacteria should be, there's just empty space.
A phantom menace.
Sometimes you might see a faint, tiny pink haze if you leave the counter stain on for a long time, but for all practical purposes, they are completely invisible on Gram stain.
Which means the Gram stain is clinically useless here. If you suspect mycoplasma, you have to rely on other tools.
Absolutely useless.
We'll get to the modern diagnostics in a bit, but first, let's look at the weaponry. How does this tiny, wall-less, invisible blob actually cause so much damage to our lungs, specifically focusing on Mycoplasma pneumonia?
The most crucial concept to grasp here is that M. pneumonia is an extracellular pathogen.
So it doesn't invade our cells like a virus or a chlamydia.
Almost never. It stays on the outside. It's a clinger.
The ultimate stage 5 clinger.
It really is.
Yeah.
And to do that, it has evolved a highly specialized structural weapon. One end of the bacterium is tapered into a specialized attachment tip. And right at the apex of that tip is a complex of proteins.
And the MVP of that complex is the P1 adhesin.
The P1 adhesin. Think of it as a microscopic grappling hook.
What does the grappling hook grab onto?
It is perfectly shaped to bind to sialylating glycoprotein receptors. And where are those receptors? They are highly concentrated at the base of the cilia on our respiratory epithelial cells.
Let's visualize this for the listener. You're in a crowded dorm, someone coughs, you inhale a droplet, the mycoplasma floats down into your trachea or your bronchi. It ignores the smooth squamous cells. It specifically hunts down the ciliated cell.
Right, the cells that are responsible for the mucociliary escalator, the ones sweeping the mucus and the debris up and out of your lungs.
So the bacterium finds the cilium, fires the P1 grappling hook, and latches onto the base. Then what?
Once it anchors securely, it causes a phenomenon called ciliostasis.
The cilia literally stop beating.
They freeze, the escalator stops, and eventually the bacteria destroy those ciliated cells entirely.
Which is catastrophic for the airway. That escalator is our primary mechanical defense. It's the trash collector. If it breaks down, the mucus, the dead cells, and other ambient bacteria just sit there and pool in the lungs.
This is the exact mechanical reason for the hallmark symptom. That persistent, nagging, dry, hacking cough. Your body is desperately trying to manually force out the garbage that the cilia can no longer sweep away silently.
So the physical attachment is doing huge damage. But Murray points out that the bacteria is also chemically toxic.
Yes, and Jowis goes into great detail on this. Once attached, these bacteria start metabolizing, and their byproducts are highly toxic. They secrete hydrogen peroxide and superoxide radicals directly onto the human tissue.
They're literally pouring bleach on our lung cells.
Essentially, yes. It causes severe local oxidative stress and tissue necrosis.
But the real twist here, and this is perhaps the biggest conceptual anchor for the whole chapter, is that the bug's bleach and the grappling hook are only half the story. The bacteria itself might actually be the minor partner in the overall destruction.
It's true. Much of the clinical disease you see in a mycoplasma infection isn't from the bacteria, it's from you.
The host response.
Mycoplasma pneumonia acts as a superantigen.
Oh, wow. So it totally short-circuits the immune system.
It does. It stimulates a massive, uncoordinated migration of inflammatory cells to the lungs, macrophages, lymphocytes, and triggers them to dump huge amounts of inflammatory cytokines.
TNF-alpha, IL-1, IL-6.
Exactly. It initiates a localized cytokine storm.
So the fluid filling the airway walls, the systemic fever, the profound fatigue, that's not directly the mycoplasma. That's our own immune system overreacting and carpet bombing the area.
Our immune system shows up to kill the intruder, and in the crossfire, it severely inflames and damages our own lung tissue. This is why patients feel so completely awful even if the actual bacterial load in their body is relatively low.
And this brings us perfectly to the clinical concept of walking pneumonia, atypical pneumonia. The patient comes in, they feel like absolute garbage. They have this dry, hacking cough that won't stop. But they aren't usually septic and bedridden like a classic strep pneumo patient.
Right. With typical pneumococcal pneumonia, the air sacs, the alveoli, fill up with thick pus. You can't exchange oxygen. You are hypoxic and stuck in bed. But with mycoplasma, the inflammation is mostly interstitial.
It's in the walls of the airways, not filling the sacs themselves.
Exactly. So gas exchange is impaired, but not entirely blocked. The patient isn't severely hypoxic, so they're literally walking around.
Walking around the grocery store, going to class, coughing on everyone.
Spreading it highly effectively.
Which perfectly transitions us to the epidemiology. Who is actually getting this?
Well, importantly, Mycoplasma pneumonia is a strict human pathogen. There's no animal reservoir. You don't get it from birds or ticks. We give it directly to each other.
Via large respiratory droplets.
Yes. Coughing, sneezing, close talking. And it's often referred to as the school-age bug.
So we're talking 5 to 15 years old.
That's the peak demographic.
Yeah.
But it also dominates in what we call closed populations. Military recruits in basic training, college students living in dorms, boarding schools.
Basically, anywhere you take healthy young adults and pack them into tight living quarters.
Mycoplasma absolutely thrives in those environments. The attack rate is incredibly high.
What's the attack rate like in a household?
If one person in a family brings it home, the secondary attack rate among close family members is around 60%.
Wow. So if your 10-year-old gets it, the whole house is probably going down.
Highly likely. And it's a slow burn. The incubation period is long, up to 4 weeks. So it slowly marches through the family over a month.
Exam clue right there.
Ah.
If the vignette describes a 19-year-old military recruit or a 10-year-old kid with a non-productive cough and a low-grade fever, your brain should immediately scream mycoplasma.
Absolutely. It's a classic association.
Now, does it have a season, like how flu and RSV are winter bugs?
No, and that's an important differentiator. Mycoplasma happens year-round. However, it does have these weird epidemic cycles. We see massive spikes in cases every 4 to 8 years. We don't fully understand the global dynamics of why, but it reliably surges cyclically.
What about the epidemiology of the genital species? Genitalium and homines?
That's entirely driven by sexual activity. Colonization rates are near zero in childhood and then increase dramatically after puberty. Murray explicitly states that carriage rates correlate directly with the number of lifetime sexual partners.
So it tracks very similarly to the epidemiology of chlamydia or gonorrhea.
Very closely.
Let's dig deeper into the clinical diseases section. We touched on walking pneumonia, but let's talk about the radiology. What does it actually look like on a chest x-ray?
This is a huge testable differentiator. If you order a chest x-ray on a patient with classic strep pneumonia, you typically see lobar consolidation.
An entire lobe of the lung is completely dense,
Yeah.
white, and solid, like a brick.
Exactly. But with mycoplasma, because the immune response is attacking the interstitium, the supportive tissue between the air sacs, the x-ray looks completely different. It looks streaky, patchy.
Patchy interstitial infiltrates.
Or patchy bronchopneumonia. It's diffuse. And this leads to a classic clinical maxim. With mycoplasma, the x-ray often looks worse than the patient.
Meaning you see these crazy bilateral streaks on the film, but the patient is sitting up, talking to you, in breathing room air.
Exactly. There's a clinical radiographic disconnect.
But, and this is where mycoplasma gets really sinister and where exam writers love to focus, the lung is only the beginning. Murray highlights these incredible extrapulmonary complications. The bug stays in the lung, but the body goes haywire systemically.
This is fascinating biology. Even though the bacteria itself rarely invades the bloodstream, the massive inflammatory response spreads everywhere. You can see severe neurological issues.
Like meningoencephalitis.
Yes, meningoencephalitis, transverse myelitis, even ascending paralysis mimicking Guillain-Barré.
What about the heart?
Pericarditis is a known complication. And then dermatologic issues are huge.
We're talking about rashes.
Severe ones. Erythema multiforme, and specifically Stevens-Johnson syndrome, or SJS. Mycoplasma pneumonia is actually one of the most common infectious triggers for SJS in children.
For the listeners, SJS is that terrifying mucocutaneous reaction where the skin and mucous membranes literally blister and slee off. It's an immune complex mediated emergency.
Very serious. But out of all the extrapulmonary complications, the most famous, the one that is absolute board exam gold, is hematologic.
Hemolytic anemia.
Yes. A significant subset of these patients get the pneumonia, and then suddenly their red blood cell counts tank. Their RBCs start bursting.
Okay, we really need to break this mechanism down. Why does a respiratory infection make your red blood cells explode?
It's the ultimate case of mistaken identity. Friendly fire. We talked about how the body mounts a huge antibody response, right?
Right. It makes tons of IgM antibodies early in the infection to fight the mycoplasma.
Well, the Mycoplasma surface antigens are somewhat similar to human antigens. So some of the IgM antibodies your body produces are cross-reactive. They're sloppy.
They get confused.
They bind to the bacteria, sure, but they also accidentally recognize and bind to a specific antigen on the surface of human red blood cells.
The I antigen, capital I.
Exactly, the I antigen. But here is the bizarre physics twist. These specific cross-reactive antibodies have a thermal preference. They only bind tightly at cold temperatures, specifically around 4 degrees Celsius.
Which is why we call them cold agglutinins.
Exactly. So think about the human body. In the warm central core, the heart, the lungs, the brain, where it's 37 degrees Celsius, the antibodies don't stick to the red blood cells very well. They just float right past.
But when the blood circulates out to the periphery, the fingers, the toes, the tip of the nose, the earlobes, areas exposed to cold air,
The blood physically cools down. And as it cools, those cold agglutinin IgM antibodies suddenly latch onto the I antigen on the red blood cells.
and IgM is a massive pentamer. It's huge, so it can grab multiple red blood cells at once.
It cross-links them.
Yeah.
It causes the red blood cells to physically clump together, which is called agglutination. And worse, it activates the complement cascade right there on the cell surface.
And complement punches holes in the cells. Boom. Hemolysis.
So clinically, you might have a patient recovering from a nagging cough who suddenly complains that their fingertips turn blue and incredibly painful whenever they hold a cold soda can or go outside in the winter.
Raynaud's phenomenon.
Exactly, secondary to the cold agglutinins. Or if you draw their blood into a tube and you leave that tube sitting on the cold granite counter in the lab.
The blood inside the tube will visibly clump up like sand.
It's a striking visual.
That is such a brilliantly weird mechanism. The cold agglutinins are iconic. But we should pivot to how we actually diagnose this bug in the modern era, because there's a huge trap here regarding those cold agglutinins.
A massive trap.
Let's set the stage. Patient comes in, 20 years old, dry cough, patchy chest x-ray. You suspect mycoplasma. We already said gram stain is a waste of time. No wall, no dye.
Right. And antigen tests, like the rapid swags we use for strep or flu, they exist for mycoplasma, but Murray points out they have terrible sensitivity and specificity. They aren't recommended.
Okay, so we're left with culture, serology, or molecular tests. Let's look at culture. We established they need custom sterile media, but theoretically, it's possible.
It's possible in a specialized reference lab.
Yeah.
But for a clinician, it takes 2 to 6 weeks for those tiny mulberry colonies to grow.
Which means by the time the lab calls you with a positive result, the patient has either spontaneously recovered or they're in the ICU.
Exactly. Culture is the gold standard for proving eradication in a research setting, but for acute diagnosis at the bedside, it's totally useless.
So that leaves serology blood tests and PCR. Let's tackle the serology trap, the cold agglutinin test. We just spent 5 minutes raving about the mechanism. It's famous.
Historically, checking a cold agglutinin titer was the way you diagnose mycoplasma. If you saw a high titer of IgM cold agglutinins, usually a dilution greater than 1.64, you said, aha, mycoplasma.
Dud.
But it is notoriously nonspecific. Mycoplasma causes it, yes, but so does Epstein-Barr virus, cytomegalovirus, even some lymphomas, and worse, it's insensitive. Only about 50% of patients with Mycoplasma pneumonia actually produce high enough levels of cold agglutinins to trigger a positive test.
So you flip a coin.
You flip a coin, and even if it's heads, it might be mono instead. Murray is absolutely explicit here, and I want to emphasize this for the medical students listening. Cold agglutinin testing should not be performed for diagnosis anymore.
This is the ultimate exam versus reality distinction. On a multiple choice board exam, they will absolutely give you the cold agglutinin history, the blue fingers, the clumping blood as a massive clue to point you toward mycoplasma.
Right, you need to know the mechanism cold, pun intended.
But if the question asks what is the best diagnostic test to order, do not pick the cold agglutinin titer.
Do not pick it.
So what is the right answer? What do we order?
PCR, nucleic acid amplification tests, or NATEs. This is the undisputed test of choice.
Because it amplifies the DNA. It's fast and highly sensitive.
You swab the throat, or you get a sputum sample, run the PCR, and you have a definitive answer in a few hours. A lot of hospitals now use respiratory multiplex panels where they swab you once, and the machine simultaneously checks for COVID, flu A, flu B, RSV, and mycoplasma pneumonia all in one run.
It's a game changer. Okay, so PCR gives us the diagnosis. Now we have to treat it. And this brings us back to the very first thing we talked about, the golden rule of Mycoplasma.
No cell wall means no beta-lactams. You must put the penicillin away, put the amoxicillin away, put the ceftriaxone away, even vancomycin. They're all completely useless.
They are heat-seeking missiles aimed at peptidoglycan, and there's no peptidoglycan here.
The bacteria literally laugh at a beta-lactam. It's intrinsically resistant.
So if we can't blow up the wall, we have to poison the inside of the cell. What are our antibiotic weapons of choice?
We have to target protein synthesis at the ribosome, or DNA replication. The three major classes are macrolides, tetracyclines, and fluoroquinolones.
Let's break those down. First line for most people.
First line, especially for children, is a macrolide, usually azithromycin.
The famous Z-Pack.
Right. It targets the 50S ribosomal subunit. We prefer it in kids because tetracyclines, like doxycycline, can cause permanent tooth discoloration and bone growth issues in young children.
But for adults, doxycycline is a great option.
Doxycycline is fantastic. It targets the 30S ribosome. And if neither of those work, or if the patient is allergic, you step up to a fluoroquinolone.
Like levofloxacin or moxifloxacin, which target DNA gyrase.
Exactly.
But we have a looming crisis here, don't we? You alluded to resistance earlier.
It is a major, major problem. In certain parts of the world, particularly in Asia, Japan, China macrolide resistance in Mycoplasma pneumonia has skyrocketed. Some studies show over 90% of isolates are resistant to azithromycin.
90%. That renders the Z-Pack effectively useless.
Completely. We are seeing those resistance genes slowly spread globally. If you have a patient who isn't responding to azithromycin after a few days, you need to have a very low threshold to switch them to doxycycline or a respiratory fluoroquinol.
Let's quickly touch on treatment for the genital species, M. hominis and M. genitalium.
Hominis has a really weird quirk. It is intrinsically resistant to erythromycin, which is an older macrolide that's highly unusual for a mycoplasma. And it's also frequently resistant to tetracyclines.
So what do you hit hominis with?
Clindamycin. Clindamycin also targets the 50S ribosome, and it works beautifully for M. hominis.
Okay, clindamycin for hominis. And genitalium.
M. Genitalium is turning into a therapeutic nightmare. It is rapidly acquiring resistance to both macrolides and fluoroquinolones. Jowitz mentions a specific strategy for M. genitalium urethritis, where you give a massive single dose of azithromycin, a full gram.
Mostly to ensure the patient actually takes the whole dose right in front of you. Directly observed therapy to aid compliance and reduce spread.
Exactly. But even with that, treatment failures are climbing. We are rapidly running out of oral options for this bug.
What about ureaplasma in those premature infants we talked about?
Macrolides are still generally the drug of choice for neonates with ureaplasma lung infections, but it requires careful pediatric infectious disease management.
Okay, so we treat it. Is there a vaccine?
No vaccine exists.
Does getting the infection at least give you lifelong immunity? Like if I suffered through walking pneumonia in college, am I safe now?
Sadly, no. The mucosal immunity wanes. You can get it again. And to make matters worse for public health, infected individuals continue to shed the bacteria in their respiratory droplets for weeks, sometimes months, even after they've taken antibiotics and feel totally fine.
Oh, wow. So isolation is impossible. You can't lock a middle schooler in their bedroom for 3 months just because they had a cough.
Exactly. Which perfectly explains why those cyclical 4 to 8 year epidemics are practically unstoppable.
All right, let's bring it all together. We have covered a massive amount of high-yield ground today. We started with the core concept, the nudist, no cell wall.
Which perfectly explains the pleomorphic shapes, the complete resistance to beta-lactam antibiotics, and why they are totally invisible on a gram stain.
We talked about their metabolic thievery. They steal cholesterol from our bodies.
The sterols, which means if you want to grow them, you have to add animal serum to your agar.
We covered their molecular weaponry. The P1 adhesin grappling hook targeting the respiratory cilia, shutting down the mucus escalator.
Cholestasis.
And we highlighted the incredible immune-mediated damage, the fact that the bug acts as a superantigen, triggering a local cytokine storm, and the production of those cross-reactive cold agglutinins that cause hemolytic anemia.
Friendly fire at 4 degrees Celsius.
We nailed the classic epidemiology, school-age kids, military recruits, closed populations.
And we locked in the modern diagnostics. PCR is the absolute king. Culture is too slow, and cold agglutinins are a historical exam trap, not a modern tool.
And finally, treatment. No penicillins. target the ribosomes or the DNA with macrolides, tetracyclines, or fluoroquinolones.
It's a really beautifully logical chapter once you anchor everything to that missing cell wall.
It really is. Now, before we hit the rapid-fire recall questions, I want to leave everyone with a provocative thought based on what we just discussed. We treat mycoplasma with antibiotics, right, to kill the bug. But we also just established that a huge portion of the actual disease, the lung damage, the fever, the hemolytic anemia, the Stevens-Johnson syndrome, all of that is immune-mediated. It's our own body overreacting.
It's the host response, yes.
And we also know that antibiotic resistance, especially to macrolides, is skyrocketing globally. So are we approaching a future where treating the bug might become secondary? Like if we run out of effective antibiotics for these mild walking pneumonias, will we have to shift our entire paradigm to treating the inflammation instead? Using biologics or targeted immune suppressants to stop the cytokine storm rather than just endlessly searching for a new antibiotic?
It's a fantastic question, and it really highlights why accurate diagnosis with PCR is so critical today. If we just blindly throw Z-Paks at every cough, we're going to accelerate that resistance timeline. It really teaches us restraint. Just because an X-ray looks relatively mild compared to strep pneumo doesn't mean the underlying immunology is simple.
It's definitely something to mull over. All right, listeners, it is time to test your attention. We're going to do our rapid-fire recall. I will read a clinical vignette or a question. I'll pause for a second so you can lock in your answer, and then our expert will reveal the answer and the why behind it.
Let's do it.
Question 1. A 12-year-old boy is diagnosed with walking pneumonia. The urgent care physician prescribes methoxycillin, but after 5 days, the patient shows absolutely no improvement. Why is this antibiotic ineffective?
Mycoplasma lacks a cell wall. Amoxicillin is a beta-lactam antibiotic that specifically targets peptidoglycan synthesis. Since Mycoplasma has no peptidoglycan, the drug has absolutely no target. If you missed that, review Murray's Section 1 on physiology.
Question 2. Mycoplasma pneumonia initiates its infection by attaching strictly to the respiratory epithelium. What is the specific bacterial protein responsible for this attachment, and what host structure does it bind to?
The bacterial protein is the P1 adhesin, and it binds specifically to sialylated glycoprotein receptors at the base of the cilia on the respiratory epithelium, leading to ciliostasis. Review Murray Section 2, Pathogenesis.
Question 3. A 25-year-old male presents with dysuria and a mild urethral discharge. Nucleic acid amplification tests for both Neisseria gonorrhea and Chlamydia trachomatis return negative. Which Mycoplasma species is the most likely culprit?
Mycoplasma genitalium. It is a major cause of nonconical urethritis or NGU, especially when chlamydia has been definitively ruled out. Review Murray Section 4, Clinical Diseases.
Question 4. You are attempting to culture mycoplasma in a research laboratory. What specific unique ingredient must be added to the agar to support the physical stability of the bacterial cell membrane?
You must add animal serum. The serum provides the exogenous sterols, the cholesterol, that Mycoplasma steals and incorporates into its membrane for osmotic stability. Review Murray Section 1 on physiology.
Question 5. A patient recovering from a severe case of Mycoplasma pneumonia suddenly develops profound fatigue and pallor. They also report that their fingers turn painfully blue whenever they go outside in the winter. What is the exact immunological mechanism behind this presentation?
The patient has developed cold agglutinins. These are cross-reactive IgM antibodies produced against the Mycoplasma that erroneously bind to the I antigen on human red blood cells at cold temperatures, causing agglutination and hemolytic anemia. Review Murray Section 4 on clinical diseases.
Question 6. Which specific Mycoplasma species is classically known for producing colonies with a distinct fried egg appearance on specialized agar?
Mycoplasma hominis. Remember that M. pneumonia typically has a granular mulberry appearance instead. If you missed that, review the Javits Chapter 25 supplement.
Question 7. Regarding oxygen requirements, how does Mycoplasma pneumonia fundamentally differ from the genital species like Mycoplasma hominis?
Mycoplasma pneumonia is a strict aerobe. It absolutely requires oxygen. Mycoplasma hominis, on the other hand, is a facultative anaerobe. Review Murray Section 1 on physiology.
Question 8, last one. What is currently considered the most sensitive and specific diagnostic test for confirming an acute Mycoplasma pneumonia infection in a clinical setting?
PCR, or nucleic acid amplification tests. It is vastly superior to culture, which is too slow, and far more accurate than serology or cold agglutinin testing, which lacks specificity. Review Murray Section 5, Laboratory Diagnosis.
How did you do? If you stumbled on any of those, take 10 minutes and quickly scan back through Murray Chapter 33 to solidify those pathways.
And remember, knowledge in medicine is a lot like a cell wall. It gives you great structure and boundaries. But sometimes, when a weird case like mycoplasma comes along, you have to be flexible to survive the wards.
Deep. Thanks for listening to the deep dive. We'll catch you on the next one.